Hello, are we all awake? I hope so. I certainly am. Woo! Because I did the Dev Days run. Are any of my co-runners already back here? One? Ah, there's more. Ah, right. Yes, that was a nice run, right? Because it was still nice and sunny. It won't stay that way, unfortunately, but we're gonna get some rain today. I have a few, before we start with today's keynote, I have a few logistic messages for you. First off, today, like yesterday, it was the nerd day. Today is the student track day, which means that we'll have 3 teams of students competing for the coolest and the best app, and they will be hacking today in the lounge, actually working on a solution. I guess they start off at the Bright Lab. Then they will hack in the lounge, and then at 3:45 today in this Wiegert room, they will do their pitches. And at 5:30 we'll announce the winner right here. Also very important today, another thing we do every year is the group photo with all of us. So we'll try to get 400 people on a single group photo. That is somewhere during lunch, so at 1:45, more or less. And you will notice, because all the yellow shirts will move like an army and try to move you to one place so we can make the picture over there. We don't know quite yet where it is, because it depends a little bit on the rain. We try to have a picture where we all stay dry. Normally we would be outside, but let's see what's going on there. Just watch the yellow shirts around lunch, more or less, and make sure you're on that group picture, because you know you will. If you weren't on the group picture, you weren't here. Then tonight is the social event at NEMO, which is our science museum right in the middle of Amsterdam. To get you there, we have buses running from 5:45, leaving from here. You can certainly also go there by your own means. I know some of you made the right decision and rented bicycles to navigate around Amsterdam, which is what all the locals do, which is what I will do. In that case, just make sure that you are in NEMO at 7 o'clock, because that's when the activities start, more or less. So if you're by your own device or a bicycle, make sure you're at 7 o'clock at NEMO. Then, still, we will ask, Martina already asked you, and I will do this again, at the reception, so where you picked up your badge, there is now this big analog thing, this old book with pages, with pictures and stuff for Rien. So if you have a personal message for Rien, don't be afraid. A few people are already brave enough to fill out something, so you won't be the first anymore. Just, take one of those big pages. You will have an empty blank spot and put a nice text there for Rien. Nice and analog, like we did this years ago. So try it. It's worth trying your handwriting once every little while and write a message for Rien. And then, unfortunately, it doesn't really happen a lot anymore. It used to be like, when I was a student, the trains were striking, I think, almost monthly, almost like the French like to do. But this Friday, the Dutch rail system is being taken down because of a train strike in the middle of the country. So if you're dependent on a train to get to Schiphol, I don't know if many of you actually do that, but I think a lot of you arrived by cab here. But there might not be trains. They might still try to get some trains for the international passengers to get to Schiphol. But if you, like most of you did, arrived here by cab, just make sure that you pre-book your cab for Friday. Because I think if you try to get an Uber or anything on Friday itself, you'll be fighting with a lot of others for a cab. So just today or whenever, pre-book your Uber, get your fixed tariff done, and then you're all set. All right, those were the logistics. So now I'm happy that I can announce our speaker. I still remember very well the first time when I met our speaker. Rien and I were about to board our plane from Schiphol to Washington, D.C. to meet him. And then there were talks of a government shutdown. And so we weren't actually sure whether when we would be flying for the 6 or 7 hours to the other side of the ocean, there would be anything to visit at all. And that was the time when there was no internet on the plane too, not that we could have done anything. So we're just like, shall we just board and see what happens? And so we flew to Washington, and luckily the government shutdown was avoided. And we were able actually to visit Don in his office. And I fully assumed that this would be a very polite and formal 10 minutes of, hi, how are you, fine, and out again. But no, we had a very engaging conversation for, I think, about an hour and a half with his whole team, until his PA said, we really should go on now. And I have still fond memories of that first meeting. So I am exceptionally happy that I can now welcome him here on stage. So have a big round of applause for Don Rucker, former National Coordinator and Chief Strategy Officer at OneUp Health.
Well, thank you for that warm introduction. Yeah, I was fascinated. You know, this company from overseas doing FHIR, you know, we were sort of, you know, a bit earlier, not totally early, but, you know, a bit earlier in figuring out how we were going to get this much richer data set out into the world and policy. You know, my job at the time was, you know, the policy and, you know, selling it to the public and selling it to my colleagues. But here we are. It's pretty amazing. And a little bit in, I'm going to be able to share some very good news, I think. The new Trump, so the Trump 2 administration, is all in on FHIR. So that, I think, will percolate through everybody in this community, no matter where you are. So that's good news. All right, yeah. So people do the right thing. So I was asked to put in a slide of who I am. The super simple thing is I'm somebody who started as a medical student, was maddened by the lack of efficiency in the American healthcare system as a first-year medical student, and said, you know, what can I do about it? Now, that's obviously a sort of an ego-rich assumption as a first-year medical student that I was going to be able to do something about it. Over the years, and it did take 50 years, so there was a little bit of a time lag, maybe not quite 50, but have been in the field ever since. And, you know, folks know me as the former national coordinator. What the successor in the current Trump, Tom Keene, was just announced this week. Tom's a great guy. He's a radiologist. He was a programmer doing C before he went to med school. So I think he gets computer science at its most fundamental memory allocation level. And today, it's my privilege also to be the Chief Strategy Officer for OneUp Health, FHIR Data in the Cloud. So I think the good news of all of this is the data, and we've always talked about data in healthcare, it's been there forever, but now I think we really are in a position to have data for compute. Historically, our data views in healthcare have been very much, let's make the paper chart electronic, a very narrow, almost a non-computable vision, but that was so daunting. And as somebody who trained in the land of paper charts, I mean, I remember I had one patient with a form of thalassemia who had 17 volumes of paper record. And so one afternoon, there were no admissions for whatever reason. I spent the whole afternoon writing a paper chart summary, so the IPS manually of this gentleman's chart. Makes you think about what data can be. In the US, and I'm going to mention things in the US here today, but honestly, I believe in almost every country in the Western world and you know, our Asian colleagues, these issues are exactly the same. Maybe the words are a little bit different, but so take out, you know, the US term, put in your term, because I think it's all the same. So the US, believe it or not, actually would just pay anybody if you submitted a bill to the big federal Medicare program, which is our payment for seniors, run by something called CMS, which is the Center for Medicaid or Medicare and Medicaid Services. I know there are two M's. That extra M was eliminated in the acronym. That agency spends about $1.5 trillion on Medicare and Medicaid. And believe it or not, the original Medicare law from '65 said we would pay anybody as long as you had a license and weren't committing obvious fraud. And so it's called any willing provider the government would pay. Well, as you might imagine, that's not the best way to shop. If you go into the store, your car dealer or bike dealer, and say, hey, I'm willing to pay anything. What do you have? The salesman is, right? Well, finally we realized around 2000, it did take 35 years, that maybe this wasn't the absolute smartest way to do things. And so we've been in the US on what we call the search for value and the end of any willing provider. Now, this is a healthcare specific thing. Healthcare economics seems to be divorced from classic economics. But it's worth thinking about classic economics because it's still actually true, sort of like the laws of physics. And how do we measure value and efficiency in the regular economy? This has been known since the early 1800s. This formula, if you can find an exception, you can win a Nobel Prize in economics, is the marginal utility, and I think most people here know sort of math at the margin, right? Calculus, et cetera, derivatives. The marginal utility of something is equal to its marginal cost, and that is a market clearing price. That is the mathematical definition of efficiency, sort of like 2 + 2 = 4. So in healthcare, in general, we don't really have market prices. So what are our proxies? And of course, here's where it gets into data, and everybody in this audience, because we're in the business of data proxies for value, right? FHIR is an abbreviation for that. You didn't know that. So what have we done over the last 25 years? Well, we've relied on something, at least in the US, but I think elsewhere potentially, called quality measurement. Right, now the thing about quality measurement is you notice there's no price, there's no cost in this equation. So there's something like deeply missing here. And if quality measures are sort of store value, how are we doing? And at least in the US, it's been a long, hard slog. I know there are folks from NCQA here. I think Ann and Kenji and some folks. Hopefully you get a chance to talk with them. And other folks have presented here in the past. But because we've been so hamstrung by the lack of FHIR, by the lack of real data, we've had to do ad hoc data munging to get even this handful of quality measures that we then apply. It's been a technically very inefficient and ugly system. So Congress in the United States, and this was, I think, already effectively the case in much of Europe, as I understand it, has basically said, we're not really going to rely on those damn doctors and hospitals. Now, they didn't actually say damn doctors and hospitals because there are too many lobbyists from the American Hospital Association and the American Medical Association prowling the halls of Congress. But subtly, what they basically said is we're going to now capitate healthcare and we're going to shift the allocation of care to the payers. This is, I mean, the NHS has been doing this now for, I think, 80 years, something on that order. And so in the US, this is a newer thing. The main programs in the government sector that do this, the one for seniors and disabled is called Medicare Advantage. It's a capitated plan. And then there's Medicaid, which is for indigents. And most states, Medicaid is federally funded and state-run, and that is very much a capitated plan. So capitation needs a lot of data to be efficient, and this gets into all kinds of things. How do you select the providers? How do you do prevention, care management? Capitated medicine, I think, has an even bigger need for data, because the moral hazard has shifted in fee-for-service from doing too much and capitation doing too little. If you follow the US healthcare news, our biggest private insurer, United Healthcare, is all over the healthcare news because of all kinds of issues here. I'm not going to get into them, but we can talk about that if folks want. It is a lot of money. It's on the order of, I believe, $600 billion. And quality measurement in Medicare Advantage is one of the main ways. There's a program called Star Ratings that has about 40 measures. The NCQA that runs that is moving to FHIR as we speak. It's a bit of a zig and a zag. But there are really vast opportunities because what FHIR allows you, the things like the claims resource, the coverage resources, at least in the US, there are financial resources in FHIR, and of course there's lots of clinical resources. So for the first time, you can combine those things. And yeah, payment and efficiency is obviously something that pays the rent and drives a lot of the system. But I think the real interesting thing, the exciting thing here, we're in an innovation center, is what is the bigger picture? What does having the ability to compute really allow you to do? I believe it really is going to allow you to do true lifetime care. Right now, most of our care is, office visits. You go there, you have an appointment. As I was sitting here yesterday, my appointment with one of my specialists was canceled, helpfully. So now I have to get it a month later. Well, I don't think that's really good for my health to delay that for a month, but yeah, there's no choice. And we can make the whole system much more efficient. So this is a very exciting time, and it is made entirely possible by FHIR. We've never had the chance to do this before. Historically, in some rough order, we had the initial lab feed, so the V2, then we had the ADT. We were never really with that able to really paint a true clinical picture. I mean, labs tell a lot. Then there was DICOM, which was forced by multi-slice CT scans, and you just physically couldn't hang up enough silver images of CT slices. So radiology had a huge forcing function. And then in the US, X12 for claims. But what was always missing, and I know the original V3 tried, was how do we represent the essence of clinical care? And that is really powerful. That's where all of this is going to end up, and there are many, many, many data opportunities here. So when you do this, I think it's worth thinking a little bit about some of the practical considerations. I think we've been so happy to just have the data in FHIR that we maybe haven't fully thought about it. I would submit, I'm not a smart enough guy to really invent a lot of stuff on my own, maybe a few things. So just copy from others who are smarter than you. It's a pretty good life strategy, and we do have the internet to help us out. And in the big data world, we sort of know what modern data open source architectures look like. Things, the Lakehouse architectures, Apache Spark, Iceberg, streaming. Those are the tools that maximize the use of FHIR and RESTful APIs. So I know each of us have the tools we have in our environment, but I would encourage you to think about those things. The challenge has been in the US, and I know globally, that our tool of record, the EMR or EHR, the electronic medical record, electronic health record, has really been a document tool and not an automation tool. We have almost no automation in healthcare when you get right down to it. In the US, the healthcare sector has, Mark Zandi from Moody's analyzed this 2 years ago for HIMSS. He showed that there's been zero growth in productivity in American healthcare from 1993 to 2023, while the rest of the economy grew aggregate in productivity 60%. So I think the EHR is one of the biggest reasons for that. I was very pleased with Seema Verma when we were in Trump 1 to get rid of the biggest incentive for fake chart notes in the US, this 10-organ review of systems and 8-organ physical exam, which made every EHR note a cut and paste operation, sort of like a ransom note, except it was always the same ransom note. No pedal edema, swelling of the feet, person might have had a bilateral knee amputation, and that's true. They didn't have swelling of the feet if you have a bilateral knee amputation. The notes were just garbage. I mean, just absolutely worthless. At the places where I practiced, the residents would click on the note before they'd even seen the patient. It was just, really? Have self-respect, but everybody's busy. So I think one of the challenges that's part of the surround of FHIR, and of course there's companies like FHIR and OneUp and many others here, maybe everybody here, is we have to build the infrastructure to really make FHIR great, because the value comes from the surround, the tools, and of course HL7's great work with implementation guides. It is pretty clear that we can imagine a world where healthcare is not episodic, visit to visit, or forfend you, come to the ER or hospitalized, but it is a continuous stream of data on our smartphones, just like email, just like banking, just like travel, just like entertainment, right? And I think FHIR is going to power an API-first world in healthcare. We've never, ever really thought of healthcare, I think, as an API-first activity, but the winners are going to do that, and I think the winners are here. So let me conclude by saying, I think we are in the right place. Kudos to Graham Grieve and all the folks, including the folks at FHIR who are pioneers in building out this very elegant standard. It's a perfect example. Just crib what was there, which was cribbing JSON. Sorry, Graham, but I think you admit that, right? I mean, we're just taking the huge richness of the internet and using that for healthcare. Think of medical care and patient computation. Think of the computation around the patient, not the site of service. Today, everything's anchored, my practice has this EHR. Think of that as site of service. Harnessing multiple financial and clinical data streams to do the value part of the equation. One thing I'll just point out as a side note, in this world of AI, FHIR is really very elegant for regularizing data. For those of you who have played with AI or have delved into the LLMs or any of the technologies, regularization of data is there. And I won't say get it for free, because FHIR is still text as opposed to numbers, but it really goes maybe the hardest part of the way in regularizing data again. So let me conclude. In the US, you may have seen with the election, Robert F. Kennedy Jr., who is, his father and uncles were iconic figures in American political and I think globally super well known. Robert F. Kennedy Jr., obviously son of RFK, who was assassinated in 1968, has made it his recent life career to make America healthy again. But the problems in American health are the exact same everywhere. We're all overweight, maybe not the Dutch, because you have so many bicycles. It's very hard to bike every day and be overweight. But the rest of the world, if you look at the World Health Organization, obesity charts, it's pretty scary. We're on the brink of a new way of looking at our environment, what we eat, what we do globally. And, I don't think we have the answers. How much of this is childhood vaccination? How much of it is food dyes? How much of it is, no exercise? How much of it is, 5 other things that come together in this incredible multivariate equation that is our body? I don't know. But as we look today, it is pretty clear that the road to modern health is going to be digital. And FHIR is a central part of that. So I think it's a great thing to be here and to have all of these wonderful sessions on the tools. And, some of it is just plain hard work. Mohammed Jini and I, one of my colleagues, were talking on what tools would we use and how would we use them and all that stuff. So anyway, that's you know, my encouragement, thanks to the hosts and organizers, and we have 2 more great days. So thank you.
Thanks, Don. Are there any questions from the room?
Or comments, or cat calls.
Well, I have a
I don't mind political questions either.
I know that. Well, I have a question then. I understand how these digital quality measures on the value side make sure that the capitation works out. But I think on your last slide, if it really goes down to our personal health, right, yes, and the FHIR API in patients, I think that also means that these digital quality measures have to come down to the level of the patient as well, not only to the level of the insurers and the providers. Have you any idea how that step is going to be made?
I think they're going to go away, to be perfectly honest with you. I think if you have a totally instrumented self, you know, you have log files, you have all of that data, and you're going to have, you know, the quality measures were put in because we didn't have outcome measures. But if we're more instrumented, we have one customer, just as an example, who has been very successful using the platform to combine very heterogeneous things. So they're combining the clinical data from the EHR, they're combining wearable data, and they're combining what I believe are FHIR survey data on the platform. So, right, something that in a classic EHR you wouldn't be able to do. And they're using it for the most topical medicine, GLP-1. So they're analyzing it that way. And I think that's going to be that combination of things where we have all of these different data streams. Right now, we've loaded a lot on quality measurement because that's all we have. And I see Ann over in the corner there. And NCQA's done great. She's hiding, but she's over there working. I don't know if her colleagues are there. You know, because that's the tool that we've had. But I think quality measure in the future is going to be a much richer process, you know, with NCQA, who's already moving in that direction. I mean, I'll give you one example. Another example of this is when I was practicing more, I was really upset by the amount of phone calls I had to make. And the phone calls were not on, like, you know, great clinical conversations, what's the differential diagnosis. They were all, you know, I was an ER doc, or am an ER doc. This was at, you know, at Penn, Ohio State. You know, is the bed ready? Is the bed clean? Why should I be spending my time checking on whether the bed is ready? Or, you know, where's the lab? So I actually wrote a software stack to analyze the entire phone traffic for Ohio State off the Cisco voice over IP switch log files and built a graph network of the entire traffic. And half of that phone traffic, which equated to 10% of the full-time equivalent employee time of the entire institution, was on calls where under 60 seconds with a median duration of 26 seconds where they were exchanging one status variable. So I think in this digital world, we're going to have so much data that some of these other things, I think, are really going to be not necessary. And then we'll have to have new tools. So then quality will be a much bigger, you know, a much bigger vision than just the narrow. That's what I think is going to happen. How much of that is thinking and how much of that is hoping? And, you know, mostly at this stage, I'm hoping that I get to see it.
And it always takes slightly longer than we always hope. Right?
Yes,
but, you know, we'll get there. Well, thanks a lot. And if there are more questions,
I'm around both days.
And there's a meet and greet behind the pink car here on the couch at 9:55.
Yeah. So,
and I know that you will be around.
Yeah.
So,
yeah. So, and I'm around the whole time.
All right.
So folks have.
Thanks again.
All right. Thanks.